Up next, we have Dr. Courtney Yarborough. She will speak on the implications of endometriosis in adolescents. Now, Dr. Yarborough is a board-certified obstetrician and gynecologist. She completed her medical training at Tulane University of Medicine in New Orleans, Louisiana. She then completed her internship and residency training at Baylor College of Medicine in Houston, Texas. She went on to complete a fellowship in pediatric and adolescent gynecology at a hospital for sick children in Toronto, Ontario, Canada. She is currently practicing as a general obstetrician and gynecologist in Barbados at number 10th Avenue in Belleville. At these locations, she evaluates and manages early pregnancies and their complications, abnormal menses, painful menses, and genitourinary infections and conditions. In addition, she counsels adolescents, young women, and adult women on STI prevention, safe sex, and the HPV vaccine. She also specializes in the care and evaluation of the specific gynecological needs of young girls and adolescents. She is dedicated to teaching young women about their gynecological needs and to empowering them to make healthy lifestyle choices for their present and their future. Ladies and gentlemen, please welcome Dr. Courtney Yarborough.
Good evening, everyone. Again, I'm Courtney Yarborough. There's a little typo and a little paper there, so that's the correct spelling there for you guys. Yarborough. Just don't look at the UGH. Yarborough. Thank you. All right. So he already told you why I got into pediatric and adolescent gynecology. I am a gynecologist by trade, but I learned early on in my life, and it's actually before medical school, that I needed to help young women take care of themselves and to learn about their gynecological health. And I figured out that this needs to be started at a younger age. So we're going to start talking about endometriosis at a younger age here. Let's first start with my first patient. So I have a patient who is 15 years old, and actually, can I move this up a little bit? Let me see. And this does represent, thank you very much. This does represent many of my patients I've actually seen here on Alino already in my 2 years here so far and in my career. So 15 years old, she presents with her mother, secondary to severe pain with her periods. Now this pain started about 2 years ago, even though her periods started when she was 11. But initially her periods were not regular, they were very irregular for those first few years, and she was not in pain. Once her period started to regulate, she started having pain with every period. And over the last 2 years, it's getting progressively worse. The first 3 days per period is the worst. She usually misses at least 2 days of school because of this pain. And pain medicine has not helped her at all. One of the reasons it hasn't helped is because you look at the associated symptoms, she has nausea and vomiting every time she has pain. So she doesn't keep down the medication. So she's at home in bed because of this pain and missing school. Her past medical, OB, GYN, surgical histories are all negative. She denies having any history of sexual abuse as well as sexual activity, and that's going to be important later, so we'll talk about that. But she does have a significant history of a maternal aunt that has endometriosis, and a mother who has never been diagnosed with endometriosis, but she did have trouble getting pregnant with the current patient. So her exam, she's on her period at the time she comes to see me, so her exam is pretty negative. She has no pain, there's no masses. I just do an external genital exam because she has not been sexually active in the past, and she and her mother feel uncomfortable with the idea of doing an internal exam. And this is okay in an adolescent who's not been sexually active. So because of that, we do an ultrasound, which is completely normal as well. So does she have endometriosis? Well, let's see. Let's go all over the details of endometriosis. So she at least has this. This is called dysmenorrhea. It's just pain with your period. And as someone said earlier, most women have pain with their period to some extent. Whether it's mild, moderate, or severe, there is some pain. And it usually begins when their cycles become regular. So they're starting to ovulate, their hormones are starting to fluctuate, and the pain starts during that time. So like our patient, she did not have pain those first 2 years, but then once her period started to regulate, her pain became worse. Dysmenorrhea can be classified into two categories. The first being primary dysmenorrhea, and that just means we have not found a structural or pathological cause for the pain. It's purely hormonal and it's causing pain during her periods. She usually does not have periods in between the periods themselves. But this is what we call a diagnosis of exclusion, meaning we need to look for other reasons for the pain before we give her this diagnosis. Secondary dysmenorrhea, there is a pathological or structural cause for the pain. It can be due to a recognized medical condition, and like Dr. Waterman mentioned before, there can be other organs in that area that can cause the pain, so you have to evaluate her for those as well. So after, let's say you treat her with pain medication and she comes back to you and there's pain still, you should consider endometriosis, okay? And we'll talk about that in more detail next. So I briefly mentioned before all the associated symptoms with dysmenorrhea. Our patient had the nausea, vomiting, and the diarrhea. And she had the recurrent short-term fluid absenteeism, which can be due to all of these things with the pain and poor sleep quality because she's in pain all the time and the pain medicine's not working. There's an increased risk of depression and or anxiety, as Ms. Roach said earlier, psychologist. So for evaluation, this is what I usually do. I will go through her complete medical, surgical, and gynecological histories, as well as her social history and her family history. All of these are very important in our patients. So for the gynecological history or the menstrual history, the timing of the pain, as mentioned before, is very important. When does it occur? Did it occur in between her periods even? That's very important in determining if this could be endometriosis for her. Social history. Is she sexually active? Because then you have to start looking at other things like sexually transmitted infections as well causing pain. Family history. Family history of endometriosis is very, very important. It is a condition that is passed along in the family. And then psychosocially, has she been abused in the past? Many times we will give patients a diagnosis of primary dysmenorrhea, but they have a past history of being abused as a child, which can be a cause of their pain. So on physical exam, we do everything. We do an abdominal exam, which is very important. The pelvic exam, though, is not always required in an adolescent, especially if they're not sexually active. I do not make them go through a pelvic exam. That alone can be traumatic for a young teenager who's not comfortable with the exam, and it's not necessary for me to make a diagnosis or to treat her appropriately. If I think she needs an exam, and there's a concern, I can do it under anesthesia. So I can give her a little medicine to make her relax, go to the operating room, and she can be under conscious sedation. Now, this is only if I think it's necessary. Okay, this does not happen all the time. I can perform an ultrasound or an MRI. An ultrasound and an MRI, these are great imaging modalities, but for endometriosis, you cannot see endometriosis on these modalities because it is microscopic. The only time you can see an endometriotic implant is if it's an endometrioma or a cyst filled with endometrial tissue. And the MRI can be performed if we suspect a congenital anomaly, and we'll go through those next, actually. But the key to this slide is that a normal ultrasound, MRI, or physical exam does not rule out endometriosis. That should still be high on the differential list for the doctor. So this is just a quick slide to when I would perform the pelvic exam in these adolescent patients. So if the patient has a history of consensual sexual activity, we usually perform the exam because there's a risk of sexually transmitted infections that can cause pain. Also, though, if they have pain that starts immediately after their period start, menarche is the first period, pain getting worse, progressively worse through the years, if they have abnormal bleeding or pain that is not related to their period, so the pain is occurring even outside their periods, then I usually do recommend a pelvic exam to make sure you're not missing anything else. And then down here at the bottom, you see again the congenital anomalies we'll talk about soon. So in my patient initially, we gave her pain medication, and then she returns to clinic in 3 months to see how she's doing, to see if the pain medicine is helping with her pain. So one of the things we have to evaluate to see if her pain is helping, if it's not helping, we have to ask, are you taking the pain medication as prescribed? Okay? And these are barriers to why she may not be taking it as prescribed. A lot of teenagers will tell me honestly, I don't remember to take pills every day. It's just really hard to take a pill every day or on a schedule or their school won't allow them to take the medication at school. That's pretty hard, so it's not going to help them as much. They may not have they may have financial difficulties as well as difficulty getting to the pharmacy, especially if the parents are not involved in this care. And then they may feel uncomfortable taking medication at school or embarrassed because their friends may see them taking the pill, or they don't want their friends to know exactly what their condition is. So these are all barriers for the treatment adherence. But even with this, if she comes back to me in 3 to 6 months and saying, it's not working for me, then we have to consider laparoscopy, which is surgery, and Dr. Barker will go into that into more detail. So 2/3 of adolescents who have come back with pain that is unresponsive to empiric treatment or pain management have endometriosis. 2/3. Now I say this because when I was training 20 years ago, or about maybe a little less, but 20 years ago, they used to teach us that endometriosis was not found in adolescents. It's an adult woman disease. And throughout my career, I have found that not to be true. And in research as well has proven this. So many doctors before me have already gone to this slide, which just tells you about what endometriosis is. It's a chronic medical condition that is mediated by inflammatory cytokines as well as estrogen. And it can get worse over time. So what are the risk factors to getting endometriosis? Well, periods before the age of 11, that's one risk factor. If your cycle is short, less than 27 days, so your menstrual cycle length is the first day of one period to the first day of the next. If that is less than 27 days, you have a higher risk of endometriosis. If you have heavy and prolonged cycles, your period is lasting longer than 7 to 8 days, maybe it's lasting 10 to 12 days, you have an increased risk of endometriosis. And with that family history I mentioned earlier, she has a 7 to 10-fold increased risk of having endometriosis alone, just from her family history. Endometriosis occurs in about 10% of reproductive age women, 40% of infertile women, and 85% of women with chronic pelvic pain. And chronic pelvic pain, the definition is you have pain that comes and goes or is constant for at least 6 months. That's the only definition of chronic pelvic pain. What causes endometriosis? As mentioned before, we really don't know. There have been many studies and many theories about what causes endometriosis. There are cells that convert from one cell to the other. Bone marrow cells are transformed. Endometrial cells are transported by the bloodstream or the lymphatic system. None of that has been really proven. The only one that we know that we can prove is when there's a congenital anomaly. So the uterus or any of the genital area down there did not form normally. So there's not a normal outflow tract for the blood, so it backs up and comes out the fallopian tubes. So between the 5th and 10th week of life inside our mommy's tummies, us girls, we have what we call these Mullerian ducts. And this is how it looks. These Mullerian ducts will then fuse together in the midline, form the uterus and the upper third of the vagina. And this is what a normal uterus and vagina looks like. And all this takes place within those first couple of months of pregnancy. If that doesn't work, these are the different types of anomalies that you can get. So if you look at this one, you see how it did not fuse in the midline. So now you have what we call a didelphic uterus, or 2 horns to the uterus. This one, on this side, there's a natural flow. But on this side here, you have a septum, or a blockage in the vagina, that's causing that blood not to come out. This kind of patient here is tricky because she'll have her periods every month and have pain, and you're just thinking it's a normal pain with her periods because she's having an outflow. Her flow is coming out. But these patients, they tend to have a buildup of blood, so eventually that pain gets worse and worse and worse with time. So with an adolescent, this is why the pelvic exam is very important, because this can be missed completely. But external, you don't see this on the outside. There's nothing on the outside that's abnormal. When she was born, there was nothing on the outside that was abnormal. This only started when she started having her periods. So when you have a patient who you treated empirically with medication, and they come back and nothing's working, this is when you start to need to do the pelvic exam, you need to do maybe an ultrasound, or you need to do an MRI. Okay? This is a transverse vaginal septum. These are different levels that are cutting straight across. This is a cervical agenesis, meaning her cervix did not form. So you still have a functioning uterus that has no outlet, okay? This one in the middle is more of the lower half, so we'll talk about it in a second, but this is a hymen. This is the hymen that did not open up inside the mom. So you have a buildup of blood. This is like a transverse section here. You have a buildup of blood inside the vagina and the uterus. And then this is called a unicornate uterus with a functioning horn. Again, the two sides did not fuse. This one is not even connected to the vagina at all. And so you have an outflow into the abdomen here, which causes implants, endometriotic implants, and pain. But these are all things that as a pediatric and adolescent gynecologist, I have to think about when I see a young lady coming in with pain, and the pain medicine is not working for her. Urogenital sinus formation. This is where the hymen comes into play. So lower down here at the bottom, this is your vagina, your urethra here, vagina there, and your rectum there. In some girls, there's not 3 openings, but just 1. Okay? The bottom half did not come together normally, and it did not open normally. So we have 1 opening. It's called a urogenital sinus formation, or cloaca is another name for it. We usually see these. This can be diagnosed right after the baby's born, though, because they have a newborn exam that should be looking at all their anatomy to make sure it looks normal. This is usually diagnosed right at that time. So at that time, they will, in the next few years, will form a opening for the bladder and the opening for the rectum. But the key to this one is that this uterus is so small, we don't know what other abnormalities she may have. So around the time of puberty, she will need to be watched closely to see if she has an outflow tract. She may not. She may have one of those other abnormalities. So girls who have this urogenital sinus formation have an increased risk of uterine anomalies as well. So we already talked about all of the signs and symptoms of dysmenorrhea, which are the same signs and symptoms of endometriosis. The key to this slide, though, is that endometriosis can be variable and unpredictable. And there are many women who actually are asymptomatic. They don't even know they have endometriosis. That's why we don't actually know the true prevalence of endometriosis. Sometimes they find out that they have endometriosis when they have another surgery for something else, and they look in the pelvis and, oh, this is a mess down there. Or they have trouble getting pregnant, but they've never had pain. So the amount of endometriosis you have does not always correlate with your symptoms. You can have other symptoms related to your GI tract. We talked about pain with defecation. You can have diarrhea and constipation. We talked about having pain with urination and bleeding during your period in your urine as well. And then we can have extragenital lesions, meaning outside of the pelvis. So the most common locations are the bladder, the urinary tract, and the ureters, as well as the bowels. But as mentioned previously, you can also have it in your lungs. If you've had a previous surgery, it can be in your scar tissue, like in the umbilicus or in your episiotomy scars. These are areas that, for some reason, you now having all this pain, and we need to look at that too. So these are areas that it can be as well, be located as well. So how do we diagnose endometriosis if we don't go straight to surgery? You have to have a high suspicion. And again, if the patient has pain that is not managed with medication, then surgery is the next step with laparoscopy. And if she's having bladder symptoms, a cystoscopy, which is just a camera being placed inside the bladder and taking a small biopsy of an area to see if there's endometriosis inside the bladder. And the only true way you can diagnose endometriosis is taking a biopsy during the surgery. You can be suspicious, you can look inside, it can be obvious, it can be not so obvious. But if you have lesions here, which are they're variable, you should take a biopsy if you're suspicious. The lesions themselves can be clear, red, brown, or powder burn. In adolescents, they are usually clear and red. And this is key because those are very difficult to identify during surgery. So if this is an example of a clear endometriotic implant. Now I'll be honest, in my early career, I would have looked at that and said, oh, that's like a little bubble. And it's the only one you see in that area. And I wouldn't have thought anything about it. But that is actually endometriosis. Other ones are, there's red spots here, and you have a little fibrosis or scarring around this one, so that's a little bit more obvious. And then the powder burn lesions here. Now the ones that are the most active and the most painful are the clear and the red ones. And then if you have any adhesions or fibrosis or scarring associated with it, that can cause pain as well. The American Society of Reproductive Medicine has a classification system that is done during surgery. This was done in 1996. There is nothing new since then. The only benefit for this staging is during surgery in your medical chart, you know how bad the endometriosis is. But the endometriotic staging is not a good predictor of future pregnancies or pain. So it's really a clinical tool being used. But in adolescents, most of the adolescents will have early stage endometriosis, which is great. So goals for treatment for the adolescent, and actually adult women as well, symptom relief is huge. Suppression of disease progression. You don't want the disease to get worse. You want to protect their future fertility. And how you treat the patient will depend on their patient choice, whether they need contraception, and any kind of contraindications to hormonal use and their potential adverse effects. And the key to this is that there's no cure, unfortunately, for endometriosis. It can only be managed. So here's the first step in treatment that I usually will perform on my adolescents. I don't go straight to surgery. This is the first thing I will do. So usually I will try pain management first. A lot of parents are uncomfortable, for lack of a better word, for their daughters to be started on hormonal medication. And I do say hormonal medication and not birth control to make them feel a little bit more comfortable. Because hormonal medications have a multitude of other benefits than just birth control. So I try to make them feel more comfortable, but if they are uncomfortable or they have not tried the continuous use of pain management, that's what I would try first. So this is what I will do. These are different types of pain medications you have here on the island. Boralgen, Aleve, ibuprofen, Constan, or Consul in some locations. It is most effective to start the medication 1 to 2 days before the bleeding starts, okay? And you want to take it on a scheduled basis, meaning you're not going to wait for the pain to start. Because once you start waiting for the pain to start, you're now behind the 8 ball, as they say. You're trying to catch up to the pain. So you start before, you take it on a scheduled basis. If it's ibuprofen and it's 800 milligrams, you take it every 8 hours. If it's Aleve and it's 500 milligrams, you take it every 12 hours. You take it on a scheduled basis up through the first 2 to 3 days of the period, where there's usually the most pain. The goal of this is to prevent them from missing school and for the severe pain, okay? And I say school, but in adult women, missing work as well and your other activities. With the NSAIDs, you have to take it with food, as mentioned earlier, and you have to take it with a greater amount of water, too. This will decrease your GI and renal effects. One key thing here, I keep hitting the wrong button. One key thing here, in adolescents, we do not recommend the use of opioids, and this is why. Adolescents can develop a dependence on opioids in as little as 7 days. Now let's say she thought her period was going to start in 2 days, but actually it started 4 days later, and she's been taking this medication now for 4 days, and now she has another 2 to 3 days of taking the medication. So that's up to 7 already, right? They have a higher risk of developing dependence on the medication, which, once they stop it, can lead to withdrawal symptoms as well. And if they take it over and over again, they can develop a state called hyperalgesia, or their pain can be, they can be so sensitive to their pain that now they need more opioid medication. But we don't recommend this as first line or even second line. This is one of the last things we'll do in a patient, an adolescent patient, and actually young women as well. You should put that as your last thing you'll do. Hormonal medications. You can start with hormonal medications right away. If they need contraception, for the fact they need contraception, start with hormonal medications. You can take birth control pills, the injections, the patches. The IUD works beautifully in this case. And this will actually, as mentioned earlier, will treat the actual condition. So it prevents the endometrial proliferation and ovulation, which decreases the, what's the word I'm looking for, hormone that causes the pain, prostaglandin, okay? You can take it continuously or traditionally cyclically. So cyclically means you take the 3 weeks and then you're off and you have a period, right? Continuously means you're taking it even during that period of time, so you don't take a break. And this has been found to have a more rapid onset of pain reduction when you take it on a continuous basis. And let's go back to the complementary treatment as well. Regular exercise, endorphins, they're huge. They are your natural painkillers. Endorphins, regular exercise and yoga has been shown to help with pain in endometriosis, as well as heating pads and acupuncture. Now the dietary supplements, there's limited evidence. Like everything else, it works for some and doesn't work for others. Vitamin D, I will recommend later on in the slides, but the rest of these, if you have a patient who, for some reason, they can't take estrogens, they had an adverse reaction to the pain medication, and they don't want surgery right now, then you can try one of these medications, one of these options, or you can even try this on top of the other options as well. Just add it to it. So second step in treatment is the surgical step, which Dr. Barker will go through in more detail. For adolescents, though, it is always conservative. What do I mean by that? You don't touch the uterus or the ovaries. They stay in place. Definitive surgery means they are gone. This is conservative surgery. So you do the conservative laparoscopic surgery or keyhole surgery for the diagnosis and treatment of endometriosis and remove as many of the endometriotic implants as possible safely, as well as any endometrioma that you see. And it's key to remove the endometrioma because sometimes they can be so large that they actually twist on themselves. And when it twists, it's called ovarian torsion. It cuts off its own blood supply, and that ovary can actually die and lose its function. And that's pretty devastating too, because now in the future she's lost an ovary for reproductive means. It's also important to remove the entire cyst and not just drain it, because they do have a tendency to come back. During the surgery, you want to get rid of any of the adhesions that you see. The reason I put this down here, the reason I don't go straight to surgery for adolescents is because there's a high re-surgery rate. 36% of women will have another surgery in their lifetime for endometriosis. It could be many reasons. They took their medication, it worked great, but then they stopped it because they want to have their family, and then when they had their family and went back, it came back. So there's many reasons why they may have surgery in the future. And it's going to be higher in younger patients. The younger you are, the more life you have in front of you, you have a higher risk of reoperation. Once they do have the surgery, though, and you have removed as many implants as possible, I do recommend putting them back on some kind of suppressive medical therapy so those endometrial implants will not grow back, or you can suppress them as long as possible. And these are the same hormones that we used before. Only time you don't do this is a young lady who's ready to start her family, and it's not an adolescent, I'm talking about an adult woman. If they're ready to start their family, you have them try to start their family right away after you've done the surgery to prevent the growth again of those implants. Now, what if treatment fails? This is where I talk about the vitamin D. So you've given the pain medications, you've given the hormones, you've given the combination, you've had the surgery, and she's still in severe agonizing pain. I've had a patient like that before. We can try what's called a GnRH agonist, as Dr. Warner mentioned earlier. This medication actually will shut off the ovaries and put you into a false menopause. So no, you're no longer producing the estrogen at that time or the progesterone. Thus, you're not producing the prostaglandin that's causing the pain. You can try this for up to 6 months in an adolescent, but at that same time, she needs to be on add-back therapy. Add-back therapy means you put her on the HRT, their hormone replacement therapy that you see in postmenopausal women, so that she can protect her bones. And I'll tell you what, I see the frown on her face already. She protects her bones because during your adolescence is when they're gaining their bones, they're strengthening their bones. So you're protecting her bones from becoming thinner, which happens in postmenopausal women, and you're protecting her against the onset of the menopausal symptoms, the hot flashes, the night sweats, the vaginal dryness, the mood swings. All of those are menopausal symptoms. And this is such a low dose, it does not make the endometriosis grow. It doesn't make the pain worse. It's just protecting her against those symptoms. We recommend using that when you start the medication. Now, in adult women, you will wait and see if they have the symptoms. You don't actually have to start it right away. So we also encourage the intake of vitamin D and calcium supplementation for the bones, and encourage weight-bearing exercises. A bone scan, which is looking for a thinning of the bones, is not recommended unless you continue the medication past 12 months, which for some women, we do use it past 12 months, but that's the only thing they can use. And once you have stopped the GnRH agonist, put them back on their hormonal suppression therapy if they can use it. So the bottom line of my entire presentation today is this. Don't delay, we're trying not to delay the diagnosis of endometriosis. Historically, it can take up to 11 years for a patient to be diagnosed. I personally have a best friend who we've been best friends for 30 years. She just had her hysterectomy at the age of 44 because of endometriosis. No children, but her pain was so bad, it was time to take it out. Her diagnosis was delayed for about 10 years. Her pain started when she was 15, and they removed one of her ovaries at the age of 15. And that's probably why I'm here today as a gynecologist. Thank you very much. Questions? Oh.
The 15-year-old,
Yes.
at the beginning,
Yes,
what was her story at the beginning?
that was my best friend I just mentioned. So she's 44, no children, hysterectomy. And she has one ovary. Can you?
If the patient is allergic to NSAIDs.
Right, so in that case, we would recommend probably the hormonal management first. And then surgery, and then, as we mentioned before, we go down the whole spectrum of possibilities.
If endometriosis is not genetically linked, what is the rationale for family history?
I think it is genetically linked. I just don't know if you know where it is.
Oh.
Because it's very common in families. It's one of the first questions I ask. Yeah. Yes.
You had mentioned the link between abuse as a child and primary dysmenorrhea. What exactly is it? Is it like the physical thing or psychological?
So it's more psychological. Sometimes women who have been abused in the past, they can have pain during intercourse, they can have pain outside of intercourse. It's just kind of like a response to their current situation. Stress can manifest in the stomach as pain. Migraines can manifest in the stomach as pain. So that's why earlier we mentioned that we have to look at other possibilities when everything else is negative. Your bowels, your urinary system, as well as your psychological system as well.
No, wait. Race, ethnicity.
It's about equal, actually. There's no African American or I'm sorry, I'm from America, so I say African American. The black and Caucasian is about equal on both sides. The strongest correlation is family history.